Last speaker then is going to talk about the U.S. experience, and this is Dr. Panjrath at GW.
Well, thank you. It's a hard act to follow, and especially this is also post-prandial, so I'm, probably going to put a lot of people to sleep here. I could probably stop and say, some of the stumbling blocks which we have in Canada are the same in U.S. as well. But I will, go a little more into our share our data here across the U.S. These are my disclosures, nothing pertinent to this talk. So when we talk about variations and challenges, I put it into three different buckets. One is in terms of outcomes, in terms of utilization, and changing phenotype as we learn from the emerging registry data. So, when we talk about our understanding of the trends in cardiogenic shock, the biggest limitation is a lot of the historical data comes from some of the administrative databases. That's a national inpatient sample, NIS database. And part of that limitation is all based on ICD-9 and 10 coding. In the historical absence of definitions of cardiogenic shock, that becomes a big limiting factor. And so what we see, the analysis obviously gets limited by that. So let's start with mortality. These are some trends, and I'm going to talk about trends in general. This is mortality trends from 14 years, over the past 14 years. This is before the shock teams came into place or just were about to come into place. And as you can see, the mortality is different in different zones within the United States, and this is based on the HCUP definition of different geographical zones within the United States. The highest mortality being in the Northeast, historically. But that also is the same geographical zone where there was a reduction in mortality over the years, over the 14 years. The greatest reduction in mortality was in the Northeast as well. And overall, the mortality has reduced, as we know. This is part of the initiatives over the past few years. And this is across all zones as well. Then what about specifically STEMI or AMI cardiogenic shock? Again, mortality being highest in the Northeast, and the rate of PCI being highest in the Midwest. And then you can see the most common device being used is in balloon pumps, and there's a variable rate of use of invasive hemodynamic monitoring. But when we look at these numbers, I think it's important to kind of also keep in mind that there's significant differences in the baseline characteristics, the age, the comorbidities, and which obviously play an influence in the outcomes in this cohort. How about breaking it up now from total cardiogenic shock into AMI cardiogenic shock as well as non-AMI cardiogenic shock? As you can see, the overall incidence has gone up. This is part of it because of better recognition, obviously more better coding, efforts towards that, and efforts to treat this condition. But in general, the trend has been towards improved survival. Again, not tremendous, but trend towards survival improvement. Now, there has been greater utilization of PCI in this AMI's cardiac shock, which is obviously in parallel to some of the efforts which have been going on, and we have seen that. There's a much greater use of percutaneous VADs or temporary MCS and ECMO, especially in the Northeast compared to the rest of the regions. And overall, historically, based on the NIS sample, the median length of stay is 6 days in this cohort. This is data on invasive hemodynamic monitoring in this population. Again, the greatest use has been in the Northeast region, which has increased. Again, part of, after the initial escape debacle, where the drop in numbers, and now the numbers have gone up due to the increasing evidence on utility of invasive hemodynamic monitoring in this population. Now, in general, if you kind of divide into these three eras, pre-LVAD, post-LVAD, as well as the shock team era, which is defined as 2015 and beyond, you can see there's a drop in use of, a relative drop in use of intra-aortic balloon pumps. There's increasing use of percutaneous VADs and ECMO in this population. And that's relevant both for AMI as well as non-AMI cardiogenic shock. These were all in-hospital mortality. Remember, this is NIS database, which is limited to in-hospital mortality, so we don't really have historically long-term data. So this is data from Innova's single-center study. Again, remember the caveat being single-center. This is after the adoption of a shock team concept, and they show that the one-year mortality is still pretty high, and which I'm not showing here is the 30-day event rate or readmissions and other events was pretty high in this group. Again, highlighting the need for heightened care despite those who survive the index hospitalization. And then there are obviously risk scores, which I think are very been discussed earlier in the morning as well. In their experience, again, in the single center experience, you can see there's increasing use of temporary MCS, more along the lines of contemporary management of cardiogenic shock now, including higher rates of Impella and ECMOs in that population. Now, despite increasing accessibility to temporary MCS, there's still a pretty big variation based on socioeconomic class and as well as race. And this is important, as we heard in the plenary session, I think, when we talk about health equity, this is something we really need to kind of address moving forward. And based on previous data, we know that Black patients with cardiogenic shock were 40% less likely to receive temporary MCS or ECMO. And socioeconomically disadvantaged households or patients with shock were 20% less likely to receive temporary MCS or 60% less likely to receive an ECMO device. So what are the challenges till now? There's limited hemodynamic data based on the previous registries, which is a big limitation when defining cardiogenic shock. Obviously, not these numbers were not classified using the SCAI categories of cardiogenic shock, and within each SCAI category, obviously, as we now start categorizing those domains, what defines the phenotypes, obviously, will define what the future outcomes are going to be. Now, moving forward, we do have some registry data, and this is due to efforts of a lot of people in this room, and this is from the CCTN network, which Dr. Bilia just talked about, and this is, we can see between around 2,100 patients, you can now, the pattern of AMI versus non-AMI shock is evolving. The majority of the patients are heart failure cardiogenic shock, and then you can obviously now differentiate between de novo heart failure cardiogenic shock versus acute and chronic, which is important because, as we'll see, the outcomes are different. There's a higher rate of SCAI score severity in the de novo heart failure cardiogenic shock group, as well as a higher rate of organ dysfunction and SOFA scores in the de novo heart failure cardiogenic shock. So overall, outcomes are worse in the de novo heart failure cardiogenic shock. There was the choice of pump has been intra-aortic balloon pump across the different categories, and the use of VA ECMO has been higher in the de novo heart failure cardiogenic shock group as well. Interestingly, the heart transplant or heart replacement therapy was less in the de novo heart failure cardiogenic shock, and we can all speculate why that probably is the case, considering there was a higher incidence of cardiac arrest in that population or on that subgroup. Now, the next registry, which is the cardiogenic shock working group registry, which is again, looking this analysis is focused only on heart failure cardiogenic shock and dividing between acute and chronic versus de novo. And as you can see, the majority of the patients were idiopathic in the de novo category, and some of the other inflammatory cardiomyopathies as well as valvular pathologies. And again, the results are very similar. The findings are very similar. Overall, in the totality of the population, the heart failure cardiogenic shock patients deteriorate pretty fast after the first 24 hours hospital admission, and the time to deterioration is actually very is shorter, especially in the de novo heart failure category. And overall incidence of cardiac arrest and in-hospital death is higher in the de novo category. This is just showing you the device utilization in this group. And in interest of time, I'm going to go fast on this. The main things are, again, use of intra-aortic balloon pump is still predominant. And fewer patients actually receive a device, acute MCS device or temporary MCS device within the 24 hours. However, within the total hospitalization, 55% of them end up requiring. So kind of giving us insights on what we need to improve on and how we need to improve identification of these patients. So in summary, I'm going to start by saying mortality is high for both AMI and non-AMI heart failure cardiogenic shock. There's changing patterns in presentation phenotypes. There's more heart failure cardiogenic shock than AMIs. There's increasing use of hemodynamic monitoring or assessment, and as well as percutaneous VAD use. There are significant geographic variations in practice patterns, in hospital outcomes. I didn't go too much into detail based on urban and non-urban environments, teaching and non-teaching hospitals. And there's variations in access to temporary MCS based on race and geography. And obviously we need more detailed information on other factors, what the inotropes, number of inotropes, duration of inotropes, doses, what those pump characteristics were, what speeds, what how their functioning was. And I'll stop there.
All right. Thank you. So that was excellent, and I think it gave you a spectrum around the world. Before we start turn to the panel, I want everybody in here has to commit now. First of all, we're going to ask 3 questions. How many are you are at an institution that has a formalized shock team? Okay, so still the minority. How many are at your institution you have a formalized shock algorithm? Okay, and how many in here are at institution that carefully looks at all their data in your own registry or part of some other registry and reviews that data? Okay, so it looks like we have a long ways to go, even with just those, I think, straightforward issues. So Joyce, why don't you start? Okay. Your comments about, well, let's go down the panel and get comments about cardiogenic shock across the world or United States. You can pick what you want to comment on.
I can't ask a question yet.
You can too. Either one.
So Phyllis, how did you, during the COVID pandemic, what did you guys do with lack of access to ECMO? And how do you decide if you have, multiple young people in 1 month that need ECMO? How do you decide who gets it?
So we were at a site which became a COVID ECMO epicenter. And everything came to us, and even across the street from us was our sick kids. It's our children's hospital, and we actually started putting adults in that hospital. And we had up to, I'd say, 40 VV ECMO patients at one time. That's probably close to the max that we had. And as a framework, actually the province of Ontario developed a framework around being very strict about who would get VV support, and also developing a framework of who wouldn't when we ran out of ventilators, pumps, everything. So there was a bit of a framework that was built. It was a very uncomfortable time. I think we all lived it in our own different ways. But what we saw was an incredible drop-off in the number of patients that needed VA, because I think they just died at home. I actually don't think they came, and people were just dying at home.
So I have a couple of questions. One for Ahmed. I was kind of surprised when you said in Saudi there is only one hospital. I was under the impression that finance shouldn't be a problem in having. That's kind of very eye-opening to me, at least.
So the problem in the healthcare system in Saudi Arabia that it's more centralized in Riyadh. So in Riyadh itself, we have 3 big centers, our center and the National Guard and the military. They all do transplant, they all do VATs. Impella, maybe I think we are the most center that we do the Impellas. But if you go to the west, to the east, we don't have that big centers. I mean, they have a cath, but the using of the MCS is not that, they don't utilize using the MCS because of lack of training, lack of protocols, same thing. But this is the problem there, that all centralized in Riyadh. And this is what we are working with the Ministry of Health that open our other centers in, in the east and in the west and north and south.
Philip, for you, a question. You had said in Canada there is 38% usage of Impella, even though it is not approved. So how do you salvage it, and how do you ever do it?
We rob Peter to pay Paul when it comes to actually the budget. So you can't hide that you're putting an Impella, because what happens is, especially if we were using it as an unloading device, Traditionally, our VA ECMO patients are being supported in our medical surgical ICU, and in order to have Impella support, all of a sudden you have to bring in a CCU nurse up there. So the resources are just astronomical in terms of costing, because you have 2 unfunded devices. Right now we're getting close to $100,000 Canadian when we convert everything down for a very long length of stay, and it was just a bit of a disaster. So we still did it. And now what's happening is we have been forced at our center in particular to say, well, the data's terrible, so how do you justify it? So we've actually gone back to our algorithm to be very specific about who would get Impella-specific support. And on top of that, we have a line item for high-risk PCI Impella support, but Impella for cardiogenic shock, we really have to take a shock team approach and make sure that we all believe in it. That it was the right choice in terms of the device.
So is there a cap? In other words, if a person comes in January compared to
No,
December,
there's no cap.
would you cap?
There's no cap. They take my salary, they do other things. No, it's interesting because as the medical director of the MCS program at our institution, the amount of emails that I would get, and you see who it's from, and you see and I would just delete it. I wouldn't even open it, and then I would get myself in trouble. But there is no cap per se.
So I practiced in Ottawa for 9 years before moving to Mayo, and I can tell you, when you put someone on MCS, you are literally robbing Peter to pay Paul, because you tie up a perfusionist. Patients are waiting 3 to 6 months for bypass surgery for left main and 3 vessel disease. So you put someone on ECMO, someone's not getting their coronary artery bypass grafting. So the decisions around use of MCS are much more thoughtful, because you are negatively impacting another patient. And so, these questions do arise in systems that aren't necessarily as well funded. You have to be really thoughtful about how you use that resource, because someone else will be negatively impacted by that decision.
Experiencing both healthcare systems.
Yeah.
Where would you rather
this
live?
This session could go forever, but we have like 2 minutes. For quick comments, quick answers. David, what you're next?
I guess my add value is that Phyllis probably doesn't know this now, but I'm about 5 kilometers from the Canadian border. So my heart failure clinic actually is, the UT is the closest center to where I do my heart failure clinic. What I observed from these 3 presenters is we have the exact same problems in the United States as we are everywhere else in the world. It's the same 10 problems everybody has, and you can just reorder them. And I think that the thing that I see the most, because in fact, New York is actually poorer than Ontario, where I am right now, it's about geography and it's about education, because the physicians don't recognize it.
Absolutely. That's why one of the biggest things we've been working on is actually education through our Canadian Cardiovascular Society. It's one of the things, we have a Canadian Critical Care Society, CanCare, that had led a cardiogenic shock day that's then become a half day. And what we have to cater to is actually the community physicians. And during COVID, that stopped, and then we started again, and it's standing room only, and it's community physicians that are coming. And what we do is, again, in October, when we're planning our next session, we're very careful that we're starting with our community care cardiologists, our emergency physicians, whoever, and then building the framework to get to the weird and wonderful. But again, it's all about education right now for us.
Okay, Peter, we're going to jump, we're going to skip, we're going to get you guys next. So Peter, comments about if you come from a whole different region.
I would like, first I would like to apologize to Canadian colleagues for the ECMO series results, because I see that making troubles with the reimbursement of ECMO in Canada, so I'm sorry for that. And I have one question I would like to ask you. Is in your countries reimbursed the same time implantation of ECMO and Impella?
Let me take a question. So the question is if
whether ECMO and Impella is reimbursed, but it's implanted in the same time.
Well, it depends. So I think, again, I can speak about our institutional experience. Obviously, we know the numbers from the database and the registry, the newer registry data. From our own institutional experience, depending on the phenotype, especially the heart failure phenotype, and if it's biventricular dysfunction, or depending on how sick they are, we are going right away with a venting strategy. Now, there are other patients we may wait and go back at a later time, but more or less we are going in right away. Yeah.